Good evening, good evening, ladies and gentlemen. This is Dr. Paul. Thank you very much for tuning to our channel today. As always, please visit my website at www.drpaul.org. That is www.drpaul.org. Please visit us for hundreds of videos we have been posting on a daily basis. Today I want to talk a few minutes about metabolic acidosis. Please listen carefully, as this is a little bit complicated process. I mean, if you don't listen carefully and understand the concepts, you don't get anything. You see, hydrogen ion concentration in human body is not typically expressed directly. We say it in terms of pH. The normal blood pH ranges from 7.36 to 7.44. Remember those numbers. The normal blood pH ranges from 7.36 to 7.44. So anything that is above 7.44 is called alkalemia, and anything that is below 7.36 is called acidemia. An acidosis is any condition which increases the amount of acid in the blood, and it is of two types: respiratory acidosis and metabolic acidosis. Now, what is the difference between respiratory acidosis and metabolic acidosis? The changes in H+, they come through volatile acids or non-volatile acids. Volatile acids is PCO2, whereas non-volatile acids are sulfuric acid and lactic acid. So respiratory acidosis is increase in volatile acid, that is, increase in PCO2 causes respiratory acidosis, whereas increase in non-volatile acid like sulfuric acid and lactic acid causes metabolic acidosis. Similarly, an alkalosis reduces the amount of acid in the blood, and it may be characterized by respiratory or metabolic. Several different buffer systems exist in the body to help maintain a pH around 7.4. And the most important extracellular buffer system is bicarbonate carbonic anhydrase system. It converts CO2 from extracellular metabolism to carbonic acid that subsequently dissociates into H+ and bicarbonate. Now, let me tell you one very, very important point. Metabolic processes affect bicarbonate concentration, whereas respiratory processes affect PCO2. That's an important point. Metabolic processes affect bicarbonate concentration, whereas respiratory processes affect PCO2. Now, let us talk about the four important acid-base conditions. Number one, respiratory acidosis. It is characterized by increase in PCO2. Number two, respiratory alkalosis. It is characterized by increased pH, that is pH more than 7.45, and a decrease in PCO2. Metabolic acidosis is characterized by decrease in pH, that is pH less than 7.35, and decrease in bicarb. Metabolic alkalosis is characterized by pH more than 7.45 and increase in bicarbonate concentration. So succinctly, those are the four important acid-base disorders. Let me talk about metabolic acidosis now. Metabolic acidosis occurs due to an imbalance between plasma concentration of H+ and bicarb, and it is defined as a decrease in bicarb to below 22 with a decrease in pH below 7.36. So pH should be low, that is less than 7.36, and bicarbonate should also be low, less than 22, in order to say that the patient has metabolic acidosis. Now, we use anion gap to help establish the etiology of metabolic acidosis. And anion gap, I will talk about it after a few minutes, but first let us see effects of metabolic acidosis. Metabolic acidosis can cause cardiovascular effects like decrease in contractility, decrease in fibrillation threshold. That means these patients develop a decreased threshold for atrial fibrillation or ventricular fibrillation. They also cause decrease in renal and hepatic blood flow, decreased cardiac responsiveness to catecholamines, and tachycardia. There are neurological effects like coma, obtundation. There are respiratory side effects like dyspnea, respiratory muscle fatigue, increased minute ventilation. There are metabolic side effects like hyperkalemia, hyperphosphatemia, increased metabolic rate, increased protein catabolism, inhibition of anaerobic metabolism. So, metabolic acidosis can be with anion gap, with an increased anion gap and a normal anion gap. Now let us see the conditions that come with increased anion gap. Basically, this is very important. Remember these conditions. Metabolic acidosis with increased anion gap. They are ketoacidosis, that is diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, renal failure, lactic acidosis, and exogenous toxins metabolized to lactate like cyanide, carbon monoxide poisoning, ibuprofen, INH, iron, strychnine, choline, and also exogenous toxins metabolized to acids like aspirin, methanol, ethylene, glycol, and paraldehyde. So those are the conditions with increased anion gap. Then there is also non-gap acidosis. This is metabolic acidosis with a normal anion gap generated by the loss of bicarbonate. So they also have increase in chloride concentration. That's why we call this hyperchloremic acidosis. And the other thing is we divide hyperchloremic acidosis into two types based on serum potassium concentration. That is hyperchloremic metabolic acidosis, then hypochloremic metabolic acidosis. So those are the two types of the non-ion gap, that is hyperchloremic metabolic acidosis. For example, with hypokalemia, we see in diarrhea, ureteral diversion, ileal loop, type 1 RTA, that is renal tubular acidosis. Whereas normal and hyperkalemic metabolic acidosis is seen in type 4 RTA, early renal failure, hydronephrosis, tubulointerstitial renal disease. So those are the basic points, and most of the times treatment of metabolic acidosis involves reperfusion. You give adequate fluids to these patients so then their tissue metabolism comes to a normal limit. In extreme cases, we give bicarbonate to these patients, but most of the times it's not necessary. So very important topic. Please remember this and visit us our website at www.drpaul.org. That is www